So now let's move on to part 3 and let's briefly talk about receiver operating characteristic curves. So what are they? So it stands for receiver operating characteristic, or ROC curve. And this is developed back in the day when they did studies on humans to see if they're able to discern true signals versus white noise in radar equipment. And this is from the 1950s, and it's based on electronic signal detection theory. But is there a clinical application? The answer, of course, is yes. So graphically, this shows us how well a test performs with respect to sensitivity and false positive rate, which we know is 1 minus specificity, at different cutoff levels. So you have to take your test and dichotomize it into yes or no at different cutoff points. For example, where I work, our high sensitivity troponin I, if it's less than 26 nanograms per liter, that's negative, and above that's positive. But what if the cutoff were 100, for example, or 1,000, or 10,000? What you'd like to do is maximize the sensitivity, so minimize underdiagnosis, and minimize the false positives to minimize the overdiagnosis. So how the curve plays out is that you have on your x-axis the false positive rate, which I call the false alarms, and then you have your true positive rate, the hits, on the y-axis. So this is the 1 minus specificity, false positive rate, and the sensitivity, true positive rate. And each circle is a different cutoff point for your test. So between positive or negative, each point is a different value for positive or negative. So an ideal ROC curve is something that's clustered to the upper left-hand corner. So all the hits and none of the false alarms, ideally. So what is the area under the curve? It's when you plot all the sensitivity versus 1 minus specificity points for the various cutoffs for your test. You determine the area under the curve, and this is done by calculus. So the higher the better, and AUC goes from 0 to 1. So a perfect test, which is 100% sensitive and has 0 false positives, would have an AUC of 1. And a useless test, which is right as often as it's wrong, would have an AUC of 0.5. So for example, here's a little diagram that I made for 3 different receiver operating characteristic curves to try to calculate the AUC. So in this one, we see that the slope is 1, straight line. So the true positive rate equal to false positive rate. So it's a coin toss. The patient have the condition? Who knows? Good test is getting closer to the upper left-hand corner, and of the 3, the green is the best one because it's clustered more to the upper left-hand corner. So all the hits, fewer false alarms. But how do you decide where the cutoff point is between normal and abnormal? So we're asking really, what are the risks of false positive versus false negatives? So risks of false positives, there'd be emotional or financial costs, stigmas, employment issues, insurance issues, a strain on the healthcare system if now you have more people who've now been identified as having a condition who might need treatment, for example. Versus the cost of false negatives, well, you might miss the opportunity to treat something, or the patient could spread disease unknowingly. So there are costs of determining what's normal and abnormal and where do you set the bar. So in summary, the ROC curves graphically shows us how well a dichotomized test performs at different cut points. It's the hits versus the false alarms, which is sensitivity versus 1 minus specificity. And the AUC, the area under the curve, the higher the better. 0.5 is useless. Your true positives equals your false positives. And a 1.0 is a perfect test. All hits, no false alarms. And you have to think to yourself, what's normal? What's abnormal? Where do we set the bar? What are the harms of over versus under diagnosis? So important things to consider.